Hello and welcome to Coproduce Care Chat. My name's Sophie Chesterglyn and I am the director at Coproduce Care. And today I am delighted to have with me again for round two, Belinda Schwehr from the charity CASCAIDr. But before we get on to Belinda, I just want to do a few introductions and simply to say that we're delighted to carry on with these live streams and we're still very new to them. So Coproduce Care, we started it as a non-profit organisation a few months ago now, end of last year, and the whole idea was to look at co-production and to see how we can talk about the social care sector in a more informative way. So not sound bites from the news, but more about opening up the care debate. So I'm supported by a fantastic team of volunteers and apprentice and others, but we're quite new to the tech, so bear with us. And what we're going to be doing is just asking a couple of things from you. We want as many people to hear about what Belinda's got to say as possible. So whether you're watching on Facebook or you're watching on YouTube, then just a couple of things you need to do is to like on YouTube. You can just subscribe to our channel. So that's the subscribe button you could see on YouTube. And if you click the bell, every time that we publish something, every time that we have a new video, we've interviewed lots of different speakers all about social care, then you'll get a notification on that. And again, if you're on Facebook or YouTube, just share. Let's get as many people watching this as possible. And let's open up the care debate. So without further ado, I'm going to introduce Belinda. Hello, Belinda.
Hello. Is that all right? Can you hear me?
I can hear you perfectly. Lovely to have you on again. And of course,
with the budgies, yes.
And you've got that. We should make a disclaimer right at the beginning. So Belinda has budgies and they will be making an appearance, a cameo in the background with the sound, but that's fine.
They love social care law, I'm afraid. It excites them. So
there you go.
About it.
So lovely to have you on again. What are you going to be talking to us about today?
Well, it's a really serious topic. It's the relationship between the number of care home deaths and the government's priority to protect the NHS. It's about reasons why so many people have not just got sick in care homes, but have actually died in situ in care homes instead of in hospital.
And can you give us a bit of an intro on CASCAIDr?
Sorry, yes. For those of people who don't know, CASCAIDr is a charity that does specialist legal advice. It does public law legal advice, which is all about enforcing people's rights and their chances for having a decent sized care package from local authorities who owe people a duty to meet their needs if it's social care that they need as opposed to healthcare. So we do healthcare law as well. And last week I spoke about the Care Act easements, focusing on the social care law side. This week it's very much on the healthcare law side. And that is a woollier and more nuanced area of law. It doesn't need to be eased because it's hard to enforce anyway. But that's what tonight's topic is about.
Great. Okay. Thanks for that. And, you know, I must say, we don't really ask for much apart from subscriptions and clicking on the bell and sharing. But CASCAIDr is a fantastic organization and you're giving a lot of advice out now for free. But obviously, if anybody wants to donate, then do feel free to. We've got the information on how to donate to CASCAIDr in the description box. And also we'll put some information in the chat for people. So Belinda, do you want to kick off and tell us sort of what are the kind of legal concerns about the number of deaths in care homes? If you could sum them up, and what I might try and share with people before you do that, some of the tweets that have been coming out and the information about deaths in care homes. I think this one is one about from the BBC News that was a few days ago, saying that care home deaths are up as hospital cases fall. And there's one you'll be talking about DNARs later. But yeah, what are the issues that you're concerned about?
Well, I got to thinking that if you added all of the people who have died in care homes to the people who have died in hospital, there was an interesting question about whether NHS critical care, intensive care capacity would have been exceeded. And because I'm a suspicious sort of a person, lawyers are, I got to thinking, well, whose agenda would that suit? And obviously, it would be important for the NHS, NHS England, Public Health England, and obviously central government, because it has been an absolute bedrock of the strategy for resolving the crisis that we protect the NHS. And because I'm a lawyer, I started to think, well, in particular, who would it affect if we did exceed capacity? And that got me to thinking about the doctors who would then have to make extremely invidious, horrific decisions as to who to prioritize for care. And because it was the same week as the litigation got some publicity about, I think it's 4 disabled people who are trying to sue Matt Hancock so that they can extract from government a hierarchy of people and the criteria by which it should be determined whether they get access to treatment or not, I started to put 2 and 2 together and started to do some legal research. So I discovered, first and foremost, if I could say this as bullets, as it were, Public Health England had started off in February actually saying, in relation to residential care, that it remains very unlikely that people receiving care in a care home or the community will become infected. So if you think back to the timeline, that was the end of February. And then that guidance was withdrawn on March the 13th, which was still another 2 weeks before lockdown. Up until that moment, people working in care homes were told that they didn't need to do anything different to what they were doing. And they were still just being told to bin tissues and told that they did not need to wear masks during day-to-day activities, and that they were only masks were only required around infected individuals if somebody, from the NHS told them so. So if we jump forwards a bit, I've been digging and I found some references in reasonably reliable sources, such as the Telegraph and the Spectator, to 40,000 people having been discharged from hospitals before the crisis really hotted up, and hospital discharge policy having changed, but not in the hospital discharge policy guidance document, that therefore appears to be unchanged. And I'm a terrier. When I get the bit between my teeth, I want to sort of wrestle it down until I can try and figure out what's happening. So if I focus on discharge policy for a minute, it's still the position that you can be discharged from a hospital having been tested for COVID and still nobody having tested you to negative. So you may or may not be tested again, but the only real improvement in hospital discharge policy, if you're going back to a care home, is that the care home will actually be told what the result of the last test was. But even if it is not negative, you will still be expected to vacate your hospital bed as soon as it's humanly possible, and then go back to isolation in a care home, if indeed that is possible. And my concern has been that, of course, during the time where the care home deaths have been going up, that has coincided spectacularly with a shortage of staff and a shortage of PPE because of the supply issues, the distribution issues, and in fact, I think behind the scenes, the procurement issues. So I'm not a conspiracy theorist, but this also coincided with the news having stuff on it about DNAR, do not attempt resuscitation forms, arriving en masse in care homes, with GPs having filled out their bit. And supposedly, I'm not sure whether this is really provable, but telling care home managers to fill out their bits precisely at the time when the relatives wouldn't be visiting. And there was even stuff about the London ambulance service having either lifted or being told to lift the threshold at which they would finally take somebody to hospital. So there's a scoring tool called News 2. And generally speaking, if you used to get a 5, you would be taken to hospital. The story went that people were getting a 7 in terms of risk to their blood pressure, their respiration and their oxygenation saturation, that they were getting scores of 7 and still not being taken to hospital. So I think all of that conspired. And it finally occurred to me that people might be being misinformed about hospital visiting, not just whether people would even get a ventilator because of the clinical frailty scoring tool that was doing the rounds, but whether if they got a ventilator, they would end up dying alone in a hospital because relatives wouldn't be able to visit them. There was a lot of news, and there still is a lot of news about visiting bans as if they were absolute or if that was lawful. So because we come at things from a perspective of the legal framework, you know, if you want to talk about any of those things, it's inevitably going to be a conversation about the law underpinning that sort of a culture. And that's before you get into like profiteering over PPE supplies and the question of whether care home providers could even get hold of the stuff once the government's parallel supply chain sort of took over. So that's why we think there should be a judge-led inquiry. I'm not into suggesting that it's negligence, corporate manslaughter, willful neglect, but I cannot get out of the ordinary media who has been driving this and why misinformation has not been able to be called out sooner, especially against the background of the rhetoric of we will find the money for whatever it takes. That for me is the concern. It just seems to me that if all of those people had died in hospital, it might have been the situation that critical care beds capacity would have been exceeded. And that's why I think people are saying that the NHS has been protected, but care homes have not. And because people in care homes are generally elderly, I do think that that's potentially an indication of the values of our society. You know, the mask, if I could call it that, the mask has slipped because those people seem to be the least important.
There's so much to unpick there.
Yeah.
And one of the things, I mean, there is a lot of talk now, or a lot of press saying that tests are being done. So you can actually get tests from the hospital for anyone who's coming back into your care home. And that's seen as a positive, and that's fantastic. But then I suppose we don't go further into say, well, if that test is positive, what then? You know, so if I don't know if people can put in the chat if they've had that experience, it'd be interesting to know. But also in terms of, you know, care homes, people who are in care homes, are you saying that they've been denied their legal rights or actually discriminated against because of their age?
I'm not brave enough to make that kind of an assertion without an evidence basis. So I can't accuse anybody or say that there's a trend. I'm simply shining a light, if you like, on the numbers and querying what would have become of the flagship strategy of protecting the NHS if people in care homes had actually got to hospital, whether or not they got treatment there, and then died in hospital. What would have what would we make of that? And that's why I'm saying I think that the only solution is an inquiry about what has driven the length of time it has taken to even get to the stage where we are saying that we test people before they go into a care home, and we test people before they are discharged from hospital, even if that test turns out to be positive. That still doesn't sound to me to be right. And I think it's a pretty unedifying situation to have come around. But I cannot say that, you know, there should be 5,000 safeguarding inquiries around the country. One of the things we've tried to do to find out more about it is we've sent a freedom of information request to every council in the country to ascertain what they knew of the well-being or the deterioration of everybody that they were paying for in care homes in the week before they died. Because I'm thinking that if you're the care planner for a client whom you're paying for, and the care home manager rings you up and says, we think this person needs to go to hospital, but we can't make the ambulance service take them, then that would have triggered a safeguarding. So we've been probing about that, not because we're into suing people, but because we think that there is an issue here that is important to saving social work and social care after the crisis is over. We have also tried to write a briefing for care home managers. It's called 10 Things That All Care Home Managers Should Know. And it's about DNARs, and it's about hospital visiting bans, and the tone and the guidance that, you know, thou shalt take whoever we throw at you. That is very much the tone of the hospital discharge guidance, which is mandating a 2-hour discharge policy from the moment somebody is fit to leave hospital. So, I mean, I can't say that it is discrimination, because very many elderly people have been taken to hospital, have been treated, have survived, and have been clapped warmly as they've managed to beat the virus. But I guess my worry is lack of legal awareness on the part of extremely stressed out NHS staff and managers, such that it's so much easier to overlook that people maybe had legal rights that have just been misunderstood.
Where can we find that briefing? Is that on your website?
Yes, it is. When I post the transcript of tonight's talk, I will add that briefing, but it was also on last week's website post as well. That briefing is on the CASCAIDr website, and I can attach links to that too for people if they're interested.
Okay.
Yeah,
that's fine. We've got the website there at the bottom.
Yeah,
I'm doing quite well with the tech, getting all the the things links up. So when you're talking about complexity, what do you mean in this briefing? You talk a little bit about, you know, how complex it is, and with the.
I can talk for England, but when I write, I get a bit more worried about what I'm writing, because of course it's got to be correct. Because once it's written down, people could pore over it, and they could much more easily take it as being legal advice. And it can't be legal advice, because it's just really public information about the legal framework. But one of the most complex things is the whole question of the DNAR forms. I was very struck by the idea that people seemed in the press to be offended that GPs would even send out DNAR forms in the first place. And I think that language is a very important thing. What did the GP say, and what had the GP done when the GP sent the forms round? It's not a bad thing in itself to offer people the chance to do a DNAR form, because the law is that a capacitated person could very well wish to ensure that inappropriate CPR that they do not want to be put through is not done to them. So a DNAR form by a capacitated person is almost like an expression of the person's autonomy. And, that's completely different from medical professionals bunging a DNAR edict on hospital records without involving people's relatives and without involving the person, because even if they lack capacity, they could still have wishes and feelings. So that's really what I'm trying to get over when I say that the briefing is bound to be complex. I do not think that care home managers are intimately acquainted with public law, human rights law, or even the Mental Capacity Act in some of its more obscure, delightful bits about, for instance, lasting power of welfare attorney and its interface with an advance decision. I think people think that a DNAR form is an advance decision by somebody else over a person's own wishes. And, people just are misinformed very often, because I think that the general media do not think that the public can absorb legal information. And that's something I'd like to see changed, because I think legal literacy is crucial. If you're a care home manager, you're like a trustee of the person's welfare. So you need to know what to say to somebody if this form is being waved in front of them. That's all that sort of rubbish,
Yeah, I know you're so passionate about this legal literacy, and it's a shame that we don't spend enough time on it, I think, in terms of training and supporting our managers, because we are under a lot of pressure. And I don't think people understand the amount of legislation that there is when you're looking after someone in a care home. I think it's just about the care home and just making staff are doing their job.
I was struck with how, if you were a care home manager, you could be full of compassion. And you wouldn't be wishing anybody any ill harm at all. What you could be thinking is, this person might die alone if they are taken to hospital, and this person's relatives aren't here for me to talk to. I can't get through to them. This person would be physically extremely weak and damaged by robust and aggressive CPR. So actually, I'm acting in the person's best interest if I just say they shouldn't be resuscitated. So I can see how it could come about through unawareness. I won't say ignorance, but through unawareness, rather than from anybody having a malign intent towards anybody that they are being paid to look after. On the other hand, if the ambulance person says, I'm not taking that person because they're over 90, if you were a care home manager, I think your duty of care extends as far as insisting that you take that paramedic's name and number, and that you get onto the ambulance trust and say, what's the source of this person's legal authority for suggesting that you can have a blanket policy of that nature?
Yes. I just want to explore some of the stuff that came up last week when they were talking about it. So Andrew Cannon here talked about exactly what you were saying about GPs contacting teams and saying that they want to use these DNRs. So is there a difference actually between do not resuscitate and do not attempt resuscitation? Is it just the same thing with
it's the same thing? It's the same thing. And sometimes they're called DNA CPR. So that's typically, the cardiopulmonary resuscitation.
Yeah. And we've already seen that before. Yeah. So that's really what people were talking about. But I mean, is there anything else that's been kind of worrying in this area, maybe affecting people themselves or their relatives?
Do you mean about DNAR stuff, or do you mean other concerns?
Yeah, maybe around sort of hospital visits you talked about earlier, and some of the guidance around that.
Yeah, well, I mean, it's been full on in the newspaper about people not being able to be with their relatives in hospital. And then you see more news reports of people sitting around the parent's bed, for instance, in the hospital, one or two relatives, and it's too late to have the conversation, and it's too late to do this, and it's too late to do that, and it's very, very sad. And I think that there's nothing more distressing than the care home media footage where people are at the windows talking to people or trying to talk to people who are cognitively impaired. I mean, it's enough to make me cry watching it. I have a 94-year-old that lives on my premises. And I cannot imagine how I would be calm in that sort of a situation. So I got to looking into material about hospital visiting, and I discovered that it is simply not true that hospitals have been banning visits. They have been minimising visits, but they have been specifically told by the government or by NHS England that they must allow for exceptional situations, end of life care being one of them. So I think maybe it could be that people think that it's a breach of the staying at home regulations if you go to visit somebody in hospital. But in fact, it isn't, because leaving your home to provide care to a vulnerable adult is a perfectly legal thing to do. And can you imagine a police officer giving you a fixed penalty notice if you said that that was where you were headed? I just can't see that happening. So the law is that in care homes and in hospitals, there cannot be blanket bans. It's easier to establish that for hospitals because they're public buildings. But care homes that have got any publicly funded clients in them also owe human rights to those clients directly under the legal framework. And therefore, they have to consider people's right to respect for their home, their private life, and their family life. And they have to consider the relatives as well. So I would be very surprised if there was case law suggesting that it was legal for care homes to have a blanket 100% ban on visitors. There has been a couple of cases in the last week about best interests assessors and other relatives visiting people in care homes. But the case law is ambiguous in those cases because it's been affected by the judge in one of the lower levels of the case actually thinking it was appropriate to derogate from the European Convention. As far as I know, the United Kingdom has not taken the judge up on that suggestion. So, I mean, that case law is a bit under a cloud. And the judges are very, very clear that people must carry on doing best interest and mental capacity assessments remotely if there really is no other safe way of getting into a care home. So it's not just about what you ban, it's about what you facilitate, you know, including opening the windows and providing for iPads and providing the staff to facilitate the contact with the relatives. So that particular issue, I think, will have had a very baleful effect on people's willingness to fill out a DNAR form, or people's determination to get a person who was deteriorating to hospital. That was my concern.
I'm going to just move on to some other topics in a minute, but I wanted to go over and cast our eyes over the comments. And thank you for your comments, because it makes for a bit more of a vibrant discussion. So I don't know if you could see some of them there. There's one person who had a specific issue.
I can see hundreds of issues.
Lots of links.
Yes. What one?
Yeah, I think somebody is asking about, can you explain if the DNAR will stand after this is over? And they're just talking about a case that they have where their GP is working with them during this time and calling families to check. However, in the next 3 months, things might be very different. And of course, we are living in a time where guidance, you know, last week was changing every day, every other day, and things are very, you know, changeable. And we're set at the weekend to get some information about what's going to happen about easing the lockdown. So, do you think, how long will these changes stand?
If you are a capacitated person and you do a formal advance decision, you can tear it up any time, and you can change your mind and accept treatment almost with your dying breath if you want to. You can change your mind and you do not have to do it formally. And with a DNAR, it's similar. If you yourself have signed a DNAR, you can arrange to tear that up at any time you like. And that doesn't mean that a doctor would attempt resuscitation, because it's always going to be a clinical decision as to whether to even offer it to you. A judge can't make a clinician do CPR if the clinician thinks it would be unethical or simply irrational because there was no prospect of it working. So if you're capacitated, you can tear up your DNAR. If in fact you lack capacity and all the DNAR represents is other people's opinions as to what would be in your best interests if you were to cease breathing, then the question, it should be, I think, whether it is time limited, specific or not, should be analysed with reference to why it was anybody's opinion that you should not be resuscitated. If it was because you had a deteriorating terminal condition with no quality of life as far as your relatives were concerned, then it is unlikely that the end of the COVID crisis will have changed that situation for the better. But supposing you were in a coma, and not an induced coma, but in a coma, and it didn't seem that you were coming out of it, but you then did, I don't think anybody would treat your collection of DNAR opinions from Tom, Dick and Harriet and Dr. So-and-so as being ongoing forever. And that's why it's all a bit of a lottery, I think, as to who you get on the day. If a person very much doesn't want to be resuscitated, they need to do a formal advance decision whilst they still have mental capacity, because it's got to have extra special words in it and it's got to be signed and witnessed. And DNARs are, they are sort of advanced wishes. They're advanced statements, but they are not advanced decisions.
Just before we move on to the rationing of treatment, somebody has sort of collated a lot of issues that we're having and talking, I think, about the lockdown being eased. And what are your thoughts about how we as care providers, with lack of PPE and having to encourage with the current encouragement to self-isolation, and how to move forward with the potential ignoring of restricted movement from the public in general, plus the lack of testing? Is there anything in the law that can guide us with all these situations coming together?
Yeah, I think that it needs to be made crystal clear to care home managers that they are not obliged to take everyone who is thrown at them. So the tone of the hospital discharge guidance, if you remember, was very full on. It was, people will be discharged, you will take them. You will either take them back or you will take new clients, and you will all sign up to Capacity Tracker so that we know where all the vacancies are. You will do this. And the irony is that, of course, care home providers are not the partners of the state. They're not the partners of social services or CCGs, clinical commissioning groups. They are contractors. And the essence of being paid to take somebody in or back is that you do it from a willing choice at a price that is tolerable for you in terms of your business interests. So I think one of the things as we ease lockdown, but we still have loads of people needing to go back into care homes or into care homes, is there needs to be a new tone of respect from councils and the NHS about the need to pay for the cost of the care if they want care homes to continue to be willing to take in people. And that would mean that the PPE is paid for, Can you imagine a care home being willing to take clients in if there is a second wave, if the government has not paid for the first set of PPE that was needed? I think the other thing is that care planners, who still are local authorities after all, and the NHS, they need to be crystal clear about what it is they are handing over for care. Is it a person who is known to still be positive, or at least not known to be negative? Or are they handing back a person who has had 14 days since the last symptoms, and it will be given that you will get the test result within, say, 2 or 3 days? My concern is that care home managers have been made to think that they must take people in and keep the beds full, and that in some way they can have a duty of care that extends beyond their willingness to actually be a care provider. I understand about morals and ethics and reputations, but I think care home owners and care home managers would be a bit better off if they understood you can only owe a duty of care towards a person whose care you have willingly contracted for. Now, I think if you're a care home client and you've been living in a care home for a long time and you've been hospitalized, then yes, you've got a kind of higher expectation of being allowed back, whether you are privately paying or whether you are being contracted for by the council, because it's your home. And, you know, whether or not the home owes human rights, its reputation will turn on being seen to be respectful of people's connection with their care home and the residents and the staff there. But it is absolutely essential that people are care planned for specifically enough so that care home owners can know what it is they're taking on. And that's why I think CQC is doing the right thing to enumerate deaths in care homes, and also to tell the public which local authorities have adopted the Care Act easements. Because if I was a care home provider and I was taking people from a local authority that had adopted the easements, I would be particularly loath to be shouldering their responsibilities for them unless the price was right. And I don't think that that's profiteering.
No,
I think it comes from economics, you know. If beds are scarce, then the price goes up. But here it's not even the scarcity of the beds, it's the cost of the PPE, because some organisations have been price gouging.
Similar to what you've been saying, actually, I'm getting a little bit of echo on. I hope it's not affecting anybody else. Where someone made a comment, and they're a care advocate, and they found that all CCGs and local authorities in their area have suspended all NHS CHC assessment reviews and appeals and local authority care and support assessments, despite them not having adopted the Care Act easements. And there's no timescale has been given for when they will start again. So, I mean, it's possible. I mean, it's obviously happened, but should that be happening?
It's a separate thing. CHC assessment was actually suspended in hospitals by the Coronavirus Act itself. So the government took a whole section of the Coronavirus Act up to excuse CCGs from needing to do CHC assessments during the COVID crisis. And it was that suspension that meant that the hospital discharge policy needed to make it clear that everyone's care after hospitalization, whether they had COVID or not, and whether or not they had previously been funded themselves or by the local authority or by the NHS, everybody's post-hospitalization care would be funded by the NHS. And it is because if you haven't been able to decide whether a person has got continuing healthcare status and they've been in your trust in the hospital, then the NHS has still got the body, so to speak, and has not finished its responsibilities, and therefore has to pay for the follow-on care on an interim basis. So CHC assessment having been terminated doesn't mean that nobody is getting paid for by the NHS. Ironically, everybody is getting paid for by the NHS if they have been discharged from hospital since the 19th of March, when the hospital discharge policy was issued. But the question of a local authority behaving as if it has adopted the easements, but without having announced that is a separate thing, because social services are under a different legal framework to what the NHS continuing healthcare system comes under. I think that a lot of councils will be behaving as if they have adopted the easements without having announced it, but not because they're wicked, but because they haven't been abiding by the Care Act for probably the last 3 years, and they have lost the knowledge as to where the line is, and that's a different issue.
So, I mean, I don't know whether this ties in a little bit, but what about sort of rationing of treatment? Does that, what does the law say about that? I mean, that might be happening a little bit more at the moment because of resources or capacity. What's the law saying about that?
Are you talking about NHS law?
Either, really.
Well, rationing is a dirty word. The R word is considered to be almost sackable, and it's called prioritizing instead. And the legal framework for NHS treatment is that the Secretary of State has a duty to fund and organise a comprehensive health service, but that does not equate, it does not translate into an enforceable individual right on the part of any person to particular medical treatment at any given moment. So really, if we're going to tell the truth, the rhetoric is that the NHS meets all clinical needs, even in the good times. But the reality is that everybody's treatment is prioritised. And if there is insufficient to go around, there will be decision making that has to be done that no doctor will have been trained to do. If it's about literally there being more patients than there are intensive care beds, normally the prioritization is done by reference to the funding available for staff and equipment and medicine. But if we're talking here about just an absolute insufficiency of resources in terms of bed and people and equipment and PPE, then the BMA and the Royal College of Physicians, they're willing to discuss it, and so are NICE, the National Institute of Clinical Excellence. They're all willing to discuss how really terrible decisions would have to be made. One thing that NICE had put out about 4 weeks ago is something called the Clinical Frailty Scoring System. And it is a scale of 1 to 10, in respect of which everybody's clinical frailty is allocated a number. And the NICE guidance, specifically for COVID, suggests that you would not be prioritized for critical care if you score 5 or more in terms of dependency. Well, when I first read that, I was worried that it meant you wouldn't get admitted to hospital, but no, it is very clear. It is just about whether you get access to critical care. Even then, I went straight down the garden and took a photograph of my own dad standing up, adding up a column of figures with a calculator, leaning on one stick, with a sandwich in his hand that he'd just made for himself, because I was determined to have a photograph with a date stamp on it so that I would be able to show anybody that just, 2 or 3 days ago, or 2 or 3 weeks ago now, my dad was independent. because the clinical frailty score turns on dependency. There was a big hoo-ha about it then, because disabled people, people with learning disabilities or autism, and people with congenital physical disabilities were worried that because they are dependent, it would mean that they wouldn't get a ventilator. And that's what led to litigation being started by a newly formed law firm, but I don't know what's become of that litigation at this point. I don't think, because we've never supposedly exceeded NHS capacity, that anybody has been denied treatment because they were too old. But I do think that it could have happened if care home residents hadn't effectively saved the NHS from exceeding capacity by seemingly not arguing to go into hospital. So that would be a concern there.
I just want to go back to a question, actually, one of the questions, and someone's just clarifying what they were wanting to know. And they're going back to ask, how do I stand encouraging someone to self-isolate under doles? This might be a bit too much out of topic, I don't know. In a residential setting, if trackers are not irrelevant, and if I don't have, but if you don't have PPE, how do I stand legally if I can't access enough for an outbreak in our residential home?
My answer before was supposed to convey that you should say no to having a person, because
if you already have that person in your home.
If you already have that person and you're trying to isolate them, but it's proving impossible, I'm not really understanding the question, I'm afraid, and I can't see which one you're looking at. But if you're talking about the person being cognitively impaired and under a doles and still difficult to keep tabs on, as it were, and you're trying to isolate them, you are required under the Mental Capacity Act, in their best interests, to be forceful about it. I think this is what people don't understand about the Mental Capacity Act. It provides for the right to touch people even when they don't want to be touched, for their own best interests. So if a person is under a doles and it has been determined that for their own good they need to remain isolated, as well as for the good of others, then in that situation, say they have had a contact with somebody who has proved to be positive, so that they're being isolated for their own good, so that they can be properly treated at the first, tested and properly treated, then the idea of the Mental Capacity Act is you would use restraint, and that it would be part of their human rights, because it would secure their person.
And the Mental Capacity Act does talk about restrictive treatment as well. I suppose as a care provider, you'd be loath to go down that route if your staff hasn't had that training, if it's quite a difficult situation you're dealing with, but you would then do it as person-centered as you could, and you would involve the local authorities, and you'd get help in. It's not something you'd kind of just pursue by yourself.
And you'd be speaking to the GP, and the GP, if somebody was determined, albeit incapacitatedly, to be wandering around and putting themselves at risk, you would be asking the GP what could be done by way of increasing their medication regime. And I do not mean chemically coshing them, but doing something to, in the short term, prevent their restlessness. You would be liaising in that sense.
Yeah. Talking about human rights, you did just mention them there. Do human rights, to what extent do they help in the area of, say, if resources do run out, can you rely on a human rights argument somewhere?
I think it depends what you're talking about. Human rights work for both sides, because the essence of human rights is that they're all about balancing one person's interests against other people's or other groups. And I think so. I think, therefore, anybody who wants to say that we need this regime or we need that regime or we need to restrict visiting or whatever, they're going to be able to say that they're doing so compliantly. On the other hand, if you are arguing for access to treatment, you can be talking about the right to life. You won't get very far with that because it's not a right to be kept alive, no matter what. You could be arguing for freedom from inhuman and degrading treatment, but it's hard to imagine that any care provider is actually setting out to give people so little that it could be said to be inhuman or degrading. I'd be worried if I was using human rights to contend for positive steps in my personal favour when everybody else was saying that I didn't need the care as much as somebody else, or I didn't need the treatment. I'd be worried because there's been a case in the last month in which a judge specifically looks at the question of access to scarce resources in the context of human rights. It was about a lady who was taking up a hospital bed, having been offered a package of care in the community that did not suit her to accept. And she was basically saying, I won't be leaving this hospital until I get a better package of care. Well, in that situation, the hospital went to court to evict her. And although she could not be evicted as such, because there is a stay on all such proceedings, the judge used the device of an injunction to require her in the interim to leave the hospital. And he understood it would cause her great distress if anybody laid hands on her to remove her. He understood that it would be extremely distressing for her not to get the care package that she wanted. But he was not going to, I think it was a he, the judge, he was not prepared to let a person who had been genuinely regarded as not needing care in the hospital any longer take up a hospital bed. And he addressed the human rights argument and basically scotched it. So if you were to apply that to the COVID situation, my concern would be it makes it look like it's impossible to challenge a policy of rationing treatment or beds. But the judge specifically made it clear that it would be possible to challenge any public body that did that if the policy itself was discriminatory or blanket or unlawful. So, for instance, if there was a policy not to give a ventilator to anybody who was over 90, or not to let anybody back into a care home unless they'd had a negative test, a judge would probably strike down those policies. It doesn't mean that you can't have a policy, but the policy itself has to be lawful. I hope people can understand the distinction there.
Yeah, I thank you for that. Just a reminder to anyone, if you are watching on any of the platforms, Facebook or YouTube, please do like and just subscribe if you haven't subscribed already. It really does help kind of get this message out and get people interested in the kind of conversations we're trying to have. And of course, the donate and information about CASCAIDr is in the description boxes as well and in the chat. Moving on to sort of like PPE, there's the issue of being told a lot of the time by the government, and obviously that cascading down to providers through local authorities, that it is the task of providers first and foremost to source PPE. And with discussions I've been having recently, some providers are saying they literally need a full-time body 40 hours a week on that job, which is obviously something 6 weeks ago we didn't know we needed. So there's that issue. There's the issue of the cost of PPE, the quality of PPE, and the guidance as well. So it's very, very complicated. But maybe you can sort of explain from your point of view and legally where providers might stand in terms of the sort of that PPE chaos, if you like, and also concerns about profiteering.
I can't imagine what it must have been like to have been a care home owner or a care home manager and face this particular problem. For me, it's a perfect storm. The legal position, as far as I'm concerned, is that PPE, anything that is relevant to the safety of the service that you deliver, or anything that's relevant to the safety of your staff, is the primary responsibility of any care provider. And that's because of the law of negligence. And that is the reference to duty of care that we bandy about so often. I think what people can sometimes overlook is that duty of care is only to take such steps as are reasonable in all the circumstances. And from my perspective, it's not reasonable to be expected to pay for protection of these clients, even though they're owed human rights and statutory duties. They're owed them also by the NHS and councils if they have been publicly funded. So it seems to me it's not reasonable to pay for that if the fee that is being paid for the service literally is inadequate to cover the cost of buying that protection or the staffing in the particular circumstances. And I think then that shines the light on the fact that all care packages paid for by the NHS and local authorities are paid for through the medium of contract. And of course, if you are a dominant purchaser in the area, if you're buying most of the beds, then what you can do is basically tell the care home sector the terms on which you choose to do business with them and how much you're willing to pay them. But the guidance to NHS commissioners and local authority commissioners has always been to take due regard of the real cost of care. And in a specific COVID context, the guidance is utterly clear. The guidance is that commissioners, whoever is contracting and whoever is paying, will ensure that the provider's costs are covered. Because the government knows that in a market where scarcity of PPE and staffing is the order of the day, that never, ever in the history of economics has been known to put the price down. The price has gone up. So I think that the baddies would seem to be agencies who have like quadrupled the cost of staff from agency banks of staff, and the manufacturers who have just price gouged over the cost of halfway decent PPE. But I don't think that the government is helped by running the parallel supply chain in such a way that they have bought up stuff that you lot and the NHS would have been chasing as well. That just seems to have been pretty chaotic. I've read stuff about, the army tearing its hairs out because of not being able to get a grip on the logistics. And I think that, again, that's a reason that there will have to be an inquiry. I do not think that it is fair to blame providers for the difficulties that they are in when there's been 10 years worth of extremely macho commissioning on the part of the state in the first place, through austerity and through the idea that we're going to live by the market. We're going to tell you how much we'll pay. It seems to me if you live by the market, you die by the market. But it's all of us who've ever voted for that type of approach to delivery of public services who need to think maybe, would we do it differently if we had understood the lessons that COVID would dole out for us? That would be the problem, I think.
I mean, those are really strong words, Belinda. And I was about to ask you, is this the time to, it seems all doom and gloom, but actually the news yesterday was that we've got the highest death rate in Europe. And that's been overshadowed by some scientists breaking the rules, unfortunately, on the press. But that's a huge reality. And, there is time to maybe reflect now to see if we can get changes. I mean, what is the best way for providers to challenge anything that you've mentioned on the call, on, the chat today?
I think that the crucial thing that care providers need to understand is that the legal framework under which local authorities and CCGs operate involves, at least in the good times, statutory duties that they can discharge by either paying for care or by delivering it themselves. If the care home sector would not do business with local authorities and CCGs who insist on paying less than a market rate for the service, if care home owners could just be brave enough to think that they don't want to sell a crap service and that maybe their competitors don't either, they obviously can't form a cartel. They can't act anti-competitively. They can't all agree not to go lower than a particular price. But if they could be legally literate about the reason why their services are being sought in the first place, that reason being that the state owes people statutory duties, I think it would help them get a grip on the imbalance of market power. So I would say that, yes, they need to know about the Mental Capacity Act. Yes, they need to know about the law of negligence. And yes, they need to know about how to deal with CQC. But crucially, their management, their leaders, need to understand about public law realities so that they can't just be told that they can't have an increase to cover the minimum wage. They need to have the guts to say, here are your clients back again, without fearing reputational meltdown. And particularly charities, because if a charitable care home owner is providing care at less than the cost that they are having to pay out, their foundation, their trust, their charitable organisation ain't going to exist. And that cannot be the right way to run a charity.
And I think these things are going to become more and more apparent as we have voids. So people not using home care because they prefer to look after the relatives themselves or have them live with them because of the press about, the care sector and the dangers, and people struggling financially to keep going. So I think that's a really important point. And there is another one, which I don't know, we don't really have time to talk about. We've already gone over a couple of minutes. But I was on a call and they were talking about, if they're not able to, insurers potentially changing what their terms and conditions are if we as providers can't find the right PPE, and then someone comes to us, whether it's a relative or someone that we support, with a claim. I mean, maybe it's too cynical, but it is a question that other providers have been asking. Where do they stand on that? And, separate to that, I wonder, I want you to talk about your organisation in a bit as well, but there are care associations out there as well that people should or could be going to, potentially, because it's a lot for managers to deal with COVID, to deal with the Mental Capacity Act Care Act, which is like, the day job, and then to deal with what you're talking about as well. I mean, what is the way forward on that?
I can't really comment on the insurance thing, other than to say, if you were a care provider and your insurer was coming down hard on you, you should see the opportunity in that rather than it being a problem. You should see it as being the thing that gives you lead in your pencil for going back to the local authority or the CCG and saying, hell no, I won't go that low. You've got to be financially viable to be fit for purpose.
Yeah.
With CQC. So I would ultimately say public law legal literacy matters to care home providers and home care providers, because your customers are probably 50% local authorities and the NHS. So it makes sense to know the drivers that govern your own customers. It's about having strategic tools with which to have those commissioning discussions. Having said that, I run a charity, and we have had to go into a crisis mode. We have had to decide that we can't possibly expect people to pay for legal advice if the legal advice is you're on a wing and a prayer because the Care Act has been eased. So I'm not going to get into pursuing people for money for simply telling them what the legal framework is. We set ourselves up to be a legal advice charity that would solve people's problems, and yet without the legal tools, I am a particular type of provider who's had the rug pulled out from under them. But that hasn't stopped us trying to diversify, trying to see how we can sell webinars. This isn't for sale, but this is, my time is being taken up thinking about how to survive the crisis so that in the future we can go back to giving people advice about enforcing their rights. So that really is why we would be so grateful if people could bear to donate anything on our no checks donation button. I think the details are probably in the chat, but in relation to the recording of this, I know that you've put the donation details into the description box. I was really touched last week. Somebody gave a very generous donation, and they said, this is more valuable than the annual subscriptions to the Telegraph, the Times and the Guardian put together. And I really appreciated that, because I get very frustrated when journalists think that issues like this are just too intellectual to be made into digestible material for ordinary members of the population.
Thank you. Really appreciate you talking to us about this. And obviously there's a donate, but say if we did want to use your services and we wanted to pay for them, we wanted to pay for your advice, how would we go about that? And what do you do? Is it single cases that people would come to for advocacy advice?
Yes, in our normal mode, we give people, we triage people's problems. So people fill in a referral form on the CASCAIDr website. We triage those problems. And by that, I mean, we work out whether they have got a crystal clear, strong case on illegality, in which case we work for them for free. Because it's easy for us in the good times to sort those problems out. That's what the Care Act does. It gives people, some precious legal rights. If, on the other hand, they have got a less clear problem, we give them about 2.5 hours of service for free. And then we offer to help them either make a complaint or avoid the thing that they've been told is about to happen, such as a cut. We help them avoid it happening, but we charge £125 an hour. And at the moment, we're not doing that because the Care Act being eased, even if only 7 councils have adopted the easements, is still such a shock to the system that it's almost inconceivable that we would be able to help the number of people we've got to help effectively without going bankrupt, because of course we do pay our caseworkers. So yes, the service may be free for some people, but normally the chargeable work is being used to pay caseworkers who've got very specialist knowledge.
Okay.
So thank you for giving me the chance to say that. Anyway, we return to those times at some point.
Well, I don't know how long this is going to last for. But all I can say is thank you so much for joining us. And we've got details in the chat we've been putting on and in the description box, which should be below, of how to get in touch with Belinda, how to follow her, CASCAIDr, because I will just really enjoy listening to you, because no one really talks with this passion about these subjects. I mean, it's legal for someone to talk about legal stuff, and also makes it relevant to the practical stuff that we're doing every day. So yeah, I really appreciate that. So thank you, Belinda. Just a little note for people to know that we are back again tomorrow, and we will be having Asha Craig, who is a deputy mayor and councillor in Bristol City Council. So we're really looking forward to welcoming her. So if you've liked, if you've subscribed, if you've clicked on the bell, you don't even have to do anything, because it will come up straight away and you'll get notified as soon as we go live. But it's again at 7 o'clock. And you know, it's worth your while getting involved, because we're going to have Martin Green from Care England, who's also very passionate. We're going to have the CEO of Skills for Care also on a chat, and many more. But for now, we've gone on a little bit because Belinda is so interesting. And just to say thank you so much, Belinda. Have a lovely evening, and everybody out there, do stay safe. And we hope to see you again tomorrow.
Thank you. Thank you.